Okay, time for some questions. Let's do it like we did before. So, yes, please, Majid.
So Zulfi,
Professor Majid is our...
sorry, Majid is at from Imperial College London. My sort of quantitative epidemiological side is sort of very excited about this, and is very sort of sympathetic to the idea of excluding, I guess, what you call the fuzzy-wuzzy sort of evidence, and doing the numbers and sort of getting the effects of scaling up nutritional interventions on both mortality and equity, for that matter. Then I look at the macro evidence. There has been places that there has been a lot of improvements in nutrition in the past few decades, and what emerges is a lot of social determinants. Equitable income growth. There is investment in maternal education. There is good primary care. These are the things that sort of are the common features of places that have done really well at the macro level, rather than. And then, sort of you add to that the sort of recent work of Anthony Costello that actually Lancet published, that, all you had to do is just sort of empower people. You didn't have to give interventions, you actually had to do these things. So, resolve for me this tension between, do we go downstream, try to scale up these interventions and solve the equity problem, or do we deal with equity and then let sort of nutrition be solved as sort of downstream issue? I mean, where should we go?
Okay. So, I expected this from you. So thank you. I think, firstly, you've got to read the series.
I did.
So if you read the series, you will find that exactly the same point has been made throughout the series, and as you come to the concluding comment that we have put down, it talks about doing all of that. Now, do you do one to the exclusion of the other? Clearly, the answer is no. I've already made the statement that I think the best gains that you will get for improving nutrition at times have to come out of the non-nutrition sector. Come out of education, female empowerment, increasing age at first marriage. In some geographies of the world, 30 to 40% of the first births are in adolescent girls. You've got children having children. That not only impacts on the life course of the girl herself, who becomes stunted, but you really cannot do very much in that circumstance. She's going to go on to have 5 children. Bob mentioned Brazil. Brazil's done remarkably. Now, if you sit down and analyze and say, how much of that was attributable to these 10 nutrition-specific interventions, you will find that they did a lot more than these 10. So Lula and his predecessors put in a primary care program, family health program, in some of the poorest districts or poorest areas of Brazil, which targeted a whole range of things. Go to China. Now, not my favorite example, with due apologies to the Chinese, but the fact is that they achieved a lot of their gains in nutrition and reducing low birth weight rates through their one-child policy. And empowering and increasing opportunities for girls is extremely important. Now, does that mean that we don't do the nutrition-specific stuff and all go out and hope for the Arab Spring, the Pakistan Spring, or the Bangladesh Spring? The answer is no. All of those things, will take their own time. And perhaps we ought to do a combination of things, not forgetting the social determinants.
Ellen P. Wasco, Melinda Gates Foundation. Thank you, Zulfi, for a really clear presentation, and particularly thank you for explaining the differences in the approach and the models, and particularly the decision to adopt this approach of looking at the under 5 period, because I think, related to the questions and points that were raised earlier, this will actually set us up to be able to come up with that X and that Y and that Z for the post-2015 framework. And I think this is enormously helpful, even though it's quite painful to get to the point of understanding what individual differences were and why these numbers that we've all been relying on have changed in certain ways. My question here is one that we heard in the first paper, that maternal, or that about 20% of the stunning burden at 24 months, I think it was the figure given, is determined in utero or antenatally. And I didn't see, and maybe I missed it, but did you draw the line between the evidence-based maternal interventions and stunting reduction? And is this an area, because I know we have, as the foundation has funded a large number of longitudinal cohorts, and this is an area I think we could really be able to harvest existing data to answer this, if this is something where you feel that this wasn't answered or addressed.
So Ellen, thank you very much for that question, and it's a very important question. We did that exercise based on what the model told us, and we didn't present the results because it's painful. And the fact is that our current mix of interventions to address SGA firstly miss the entire period where you have a bigger value for money from your investments. So we start off with impact of balanced energy protein supplementation, calcium that we do not have a clear delivery channel for, things that we might be able to do with micronutrients, and that's it. So sadly, as Bob pointed out, maternal nutrition, and particularly maternal nutrition addressing the earlier part of pregnancy, the pre-pregnancy period, has been orphaned both in research and also in policy. So the pool of real evidence that we could draw from and model is very limited. So to answer your question directly, I think going forwards, there is probably a lot more that can be done for nutrition specific and sensitive interventions and health interventions for girls and women that can impact on the early, on both maternal health and also that early period in the first 6 to 12 months where a lot of this stunting is taking place. My last point on this is, I think this is a critically important policy agenda. We currently do not have strategies to address undernutrition in the first 6 months beyond just promotion of breastfeeding, as you know. And breastfeeding, in terms of reversing things, has very limited potential. So increasingly, we need to get the policy message out that if you are going to reduce morbidity, stunting in young infants, you've got to start very early, not just in the second trimester when the mother presents herself, but in investing in adolescent nutrition through proactive programs that specifically target this as a policy.
And can I, just before going to another question, can I just thank you and the Bill and Melinda Gates Foundation because you have invested in this work. We're very grateful. It wouldn't have happened without your investment. Thank you very much indeed for that. Question here.
Klaus Kramer, Simon Lancet. Zulfi, have you also addressed the bottlenecks and capacity required for taking nutrition to scale? Is any information
that's a great question, and if we had to do things again, we would have had a country-specific paper to address bottlenecks. We didn't. In other bodies of work, like the diarrhea and pneumonia stuff, we have a specific bottleneck approach, which is fairly similar to this. So, to answer your question, we haven't. We have used some wedges to open the door. So, the community delivery platform, for example, the evidence review of financial support strategies to reduce poverty as a barrier are a step to address some of those bottlenecks. But the larger bottlenecks that we have in terms of the supply chain, the commodities, the relationship of nutrition and the development agenda to country level ODA, those things we haven't addressed, not in this paper. We allude to it in subsequent papers, but I don't think we have done justice to it.
Yes, please.
My name is Jose Luis Alvarez. I work for Action Against Hunger. My questions are really related for coverage. You present the effects of all these nutrition interventions, always based on this 90% coverage. The first question is, how far are we from this 90% coverage on these interventions? And the second question is, you show that to achieve this coverage, we need an annual cost of many millions to achieve 90% coverage. But achieving 90% coverage may be really, really difficult. Do you think that 90% coverage is achievable with those?
Well, the 90% coverage is for this audience and a global audience to say this is what can be done. Now, if you were, I don't know where you're from, but if you were your Minister of Health, your next question to me or to other people would be, if I've got currently zero coverage of something, I get it up to 50%, what will I get? Or if I'm at 60% coverage, what do I get by increasing it by 10% year one, 10% year two? The tool allows you to do that. So for country-specific estimations, you can do a sensitivity analysis of not only overall gains that you can gain by sequential pragmatic increase in coverage, but you could also do it for various interventions. You may want to focus, if you were a Minister of Health, on just scaling up vitamin A supplementation coverage and getting your breastfeeding rates up. So what we point out is what the model will do at a fixed level of coverage, largely as an advocacy exercise. But the practical implementation of this at country level would be to take your existing programs, what data do you have on those coverage estimates within those programs, and then tailor-make your packages, the 4 packages that I talked about, according to your own needs and context.
Do you want to come back? Yeah.
Just a
sure.
small question. It's hardly difficult to find data on coverage.
It's not impossible. In the paper and in the supplement, in the web appendix, there is a link to the entire countries, the 34 countries that we have used, to the coverage data that we have for all of these interventions in the LifeSafe tool. I would very strongly encourage you to go and see that, because those coverage estimates, some may not be the best coverage estimates, but they are the best we have got. Over years, we will improve complementary feeding coverage data, effective intervention coverage data, but you have the links to the actual coverage estimates from mixed DHS surveys and other available data for these 34 countries.
Okay. Tom.
Thomas, our honorary neonatologist at Imperial College. I think it's really valuable that you've highlighted the impact of fetal growth restriction and prematurity on newborn mortality, because I think it's not been emphasized enough in the past. Those babies, though, their high-risk period is the first 48 hours of life. And I think we do need to acknowledge that really good and neonatal care during that period is vitally important for those babies to actually survive.
Tom, as a card-carrying neonatologist, I could not agree more. And I've been saying this for a long time. Very glad that finally, we had Joanne putting the evidence together around something that we as practitioners have observed for a long time. These babies who are both premature and small, which happens to be in some geographies close to half of all babies beyond 32 weeks gestation. I mean, they are at a particular risk of dying early, pulmonary hemorrhage, other complications, birth asphyxia. Now, the challenge to us is now to bring the nutrition and the neonatal community together. And not only do this in the poor geographies, but also to do it in the middle-income countries, which have now increasingly got a problem at their hands, that they have a growing prematurity burden, close to around 2 to 2.5% increase every year. And a proportion of that is also babies who are premature and growth retarded. And although we have pointed out our mortality estimates, but Joanne, you will correct us, we do not as yet have good estimates of developmental impact of that particular cohort going forward. And it may very well be that this preterm SGA group is the group which is at the greatest risk of developmental handicaps.
Yes, question at the top there, and then we'll go to
Thank you, Development from Mutual Aid. Really welcome the evidence-based approach to the interventions you've looked at. I wonder if you've had a chance to set a research agenda on the evidence that we don't have, that we suspect might be really influential. One example of that would be the prevalence of environmental enteropathy in low-income countries and the impact that has on nutrition and stunting.
So thank you for that question. I think as the day goes along, we would probably come back to that towards the end of the day. We have tried to, in individual papers, point out some research gaps, but I agree that there is probably the need to be a little bit more systematic and specific on this. So that may be forthcoming work, which will address some of those issues.
Okay, very good. Right to the back.
Hi, I'm Annie McLean from Save the Children. I wanted to kind of comment on the graph that you kind of put up and said, there might be some concerns around this graph. The graph's focusing on that one of the major helps to prevent deaths is actually management of sound. And it also came up that it's actually relatively cheap compared to other things. From my kind of point of view, I always kind of think that if we're having to treat sound, then we're doing something wrong. It's actually, the preventative measure is actually the focus. And I'm worried that this graph and also the cost that governments and other people will look at it and think we just need to focus on the treatment of sound. And that's going to be it, rather than actually focusing on preventing sound in the first place.
So the management of moderate malnutrition in here is also prevention of these kids going to severe malnutrition. all the other interventions that you see here, appropriate complementary feeding, breastfeeding, promotion, support, and maternal interventions will also reduce SAM. So there is a need for us to message that there are this graph, on the one hand, looks at what you need to do for the cohort of severely malnourished children that you already have, and what you need to do to prevent that cohort from expanding. So this is actually a combination of interventions to prevent SAM and to treat that you have an ethical imperative to treat as they exist today.
Yes, please.
Thank you, Sean Baker with Helen Keller International. Thank you for the presentation. It might not surprise you. It's very appropriate this graph is up because I wanted to speak to the vitamin A supplementation one, but I think it actually links back to the coverage and where we're starting from. And I think in Bob's presentation it was very clear that backsliding would significantly change this, but I do think it's very important not to misinterpret that. That my understanding, the additional gains and increased coverage to 90% of vitamin A supplementation are relatively small because we're at a starting point in 2011 where we're so high. I also, though, wanted to speak to the management of SAM. I think another important thing was another speaker said so that, well, obviously there's a moral imperative to treat severe acute malnutrition where it presents itself. I don't think we can assume that that child who's gone through severe acute malnutrition and be treated has the same quality of life and development potential as a child who's not been exposed to that.
I completely concur, Sean. I mean, and that's why quantifying the developmental consequences of undernutrition in a specific way is extremely important for us. Now, we may not be able to put a number on that right now in terms of this is the impact in terms of X dollars or IQ points or educational deficits, but we all know that it has. And these children who are treated today with severe malnutrition don't just have a high risk of slipping back and higher rate of mortality subsequently, but have hugely impaired and different developmental trajectories compared to others. So I couldn't agree more.
Really more thinking about today's seminar than so much focusing on the papers themselves, but where do we go? What direction do we fly in? And I've got four things I wanted to focus on. The first really is trying to shift from the notion of evidence towards plausibility, which in a way Bob hinted at and you added to, that many of us, as we built on 2008, we did a huge amount of work. It shaped a lot of our professional lives. So I think as we build on 2013, we will need to push each other during today on plausibility. Where does this take us in terms of quite major policy choices, but also quite important issues around the nature of integration that we work on, that you've brought out. Secondly, what I'm calling death versus life. But I think it's important that, having worked in public health for some decades, I've been brought up on shifting from working on mortality outcomes towards disability-adjusted life years and similar things, and now increasingly to thinking about human potential and human capital. And so I hope that we can continue to work with you today and beyond on what this work means for the capacities of individuals to be able to contribute to their full potential, themselves, in their households, in their communities, in their nations. That was my second thought. And obviously what Sally says, all my life in nutrition has been important and becomes particularly important as I listen to her exchange with you. Thirdly, it's a bit, you use in figure 2 the list model, the Lives Saved tool. And the thing that I really don't fully understand is that stunting and wasting appear as almost separate end paths to a set of causal variables, but I didn't see any explicit linkage between wasting and stunting. I mean, if I think back to my times working in Asia for some years, what we saw was that children, particularly between the ages of 6 months and 2 years, during the rainy season, the season when women were very busy, food was short and there was a lot of disease, had episodes of acute weight loss. And they became wasted, not necessarily fully wasted, 2 standard deviations below the standards, but they certainly lost weight, and you could feel it, you could see it, the mothers would tell you. And it was those children who entered the good months after the lean season thin or wasted that didn't show the subsequent 3 or 4 or 5 centimetres in length gain in the good months. It was only really 3 or 4 months a year when children grew, but it was the months after the lean season. So we saw a huge direct relationship in the communities where I worked, and I believe many ICDDRB studies showed the same, between wasting and stunting. So I'm very interested always in this particular model, this model. I've been asking questions about it because I sense there is a direct association between the processes that result in being wasted and subsequent stunting. And I wanted to ask you whether you agree. And my fourth point is something that you...
Are you writing Stanley?
Fourth point is something that you know...
It's complicated.
You know that I get funny about. And that is that you said in your summary, we have to intervene to deliver supplements, actions that will encourage breastfeeding, supplementary feeding and so on. It's there very strongly. And I keep wondering why the discourse is still fundamentally on delivery when, as you and I discussed, from my perspective, surely the real agenda now is to find ways to empower households, and particularly women, to be able to access foods or other sources of vitamins, to have the opportunity to be able to breastfeed and not to be prevented from doing so because they have to rush off to dig roads because that's the only way to get an income, or to have the time to be able to deliver food. Is the discourse inevitably always around specific interventions going to be on delivery, or can it shift to access? And you did, I noticed in your summary, use the word access, but I still feel that it's a very delivery-focused analysis. If that's too much, please scrub what seems irrelevant.
So David, I have the track changes on the document that I changed following our discourse. And I changed 17 places delivery to the kind of language that I think captures some of your sentiments. Yeah. I clearly failed in a few places actually. Anyway, I mean, just to be specific. So I'm going to start in the reverse order, and I see that Bob also wants to add. In community, when we say community platforms, because these are programs that are generally public sector programs, the term delivery is not used in the same way as you might expect. So for example, the Lady Health Workers program in my own country, one of the largest programs in the world, 100,000 community health workers. I mean, they deliver interventions, but what they deliver are largely community empowerment interventions. They work through women's groups, through interaction on a one-to-one basis, also within groups, of principally increasing community engagement, empowerment, promoting behavior change. And only a very small proportion of their task is delivering commodities. So I think I've tried to change the language in many places to talk about what these community platforms are. And I do take the point that, you know, what we are talking about is empowerment, improving access, etc. To answer your question around the outcomes and to also partly answer Sally's questions, I believe that our analysis is an excellent platform to now translate the impacts that we demonstrate on survival and also on stunting and disease burden reduction on the consequent gains that we might be able to quantify on developmental outcomes. So if the child development series from some years ago, fantastic series, set the scene by saying there is a link between stunting and poverty and delayed developmental potential. What we provide in terms of impacts is directly plausible in terms of translating some of these impacts into developmental gains. So I think there is an opportunity here, and Sun should take this up now to translate this with the data that we have. On the wasting and stunting, if there's time during the course of the day, I think we should sit down and I'll explain to you. The epidemiology overlap on the severe side and stunting is very little. And we were very careful in this model not to double count, because you can easily double count. You're treating children with moderate malnutrition and you're treating children to address stunting, and you would end up by double counting interventions. But I'm going to pass to Bob and say a few words on this.
So I do want to address your question on this. You're absolutely right. The list model does not fully represent the interactions between wasting and stunting or the prevention of wasting. So there's much more that we intend to put in. We had a discussion leading up to the preparation of this series and actually identified what was needed, but it just wasn't available in time to fully modify list. But I can tell you what is available and the intention to add it to list in the next round of revisions. One is that we now have the joint distribution of stunting and wasting by all the degrees of stunting and wasting. So what is that overlap in different settings? We now have, thanks to collaboration with Majid's group, the risk of death in all of those combinations. So this degree of stunting, this degree of wasting, what is the relative risk of death in those groups? So to use the model, we need that. And we also have to get more information, it's not complete yet, on the relationship of wasting to stunting as you described. Now, I actually have a doctoral student who just finished within the last year doing analysis of 9 longitudinal data sets with exactly that question, the relationship of wasting at different ages to ultimate stunting. And so I have all those data. The piece that's still missing a bit is the prevention of wasting and how the interventions affect those. Because most of the analyses have been prevention of stunting or prevention of underweight. Prevention of stunting literature is less clear, but we're trying to get into it. So I do expect when we tackle another complete revision, update of the Life Save tool, probably in September, when we have some new funding for that, I hope. We will. We will incorporate this, and I think the model will be more sophisticated. Although in the end, I think it will. I don't believe it will fundamentally change our results, but it'll make all of us more satisfied. We've looked at the interactions in a better way.
And just to underscore, one limitation that we have is on the interventions. That, very few of the interventions addressing SAM or MAM have looked at the impacts in terms of longitudinal models on who goes into wasting, who goes into stunting, and that is something that we hope to do from at least available data sets.
Okay, I think we need to give a big round of applause to Zulfiqar.